So the topic is shoulders. I've seen a couple folks for shoulders. Actually, in occupational medicine, we usually see shoulders. But I had someone who reminded me of my time in sports medicine. Somebody that came in was being treated by their primary care doctor for shoulder issues, went to some kind of physical therapy, and they couldn't figure out what to do, but she was starting to have problems to the clavicle here. And it was swollen, and I could obviously feel some doughy swelling over that joint. That's where the clavicle meets the sternum. On this side, it sits like this, and it meets here. And the lady had some swelling, but it turns out it wasn't anything bad. She was worried about cancer. It wasn't a lymph node. It wasn't anything bad. It was just because the shoulder, this is the right shoulder, just like this picture here, right shoulder. The shoulder has almost like a wishbone suspension for those of you who are car buffs. Wishbone suspension because it sits on the chest and it moves up and down like this. One point of pivot or movement is to the sternum. The other point is kind of flat. It sits on the back, but there are a massive amount of muscles on the back. The trapezius, I'll just flip this around. Trapezius that holds this on the back. The rhomboids that hold it towards the little middle of the back, towards the spine. The lats which hold it down. So you have, and even the pectoralis in the front gives it some support. You have all these muscles in the back holding this flat surface tacked to the shoulder or the back. The problem is when you have chronic dysfunction of one of these two pivot points, whether it's a dysfunction because you broke a clavicle or collarbone, or whether it's a dysfunction because those massive muscles, or one of those big muscles is not functioning properly. And if you kind of take a feel for everybody in your office, usually half the people will have very tight trapezius muscles right here. And remember, the trapezius muscle is supposed to lift this thing up. What do we usually do bad is hang out in a 8-hour day and kind of sit like this all day long, or drive like this with my truck drivers. Usually there's no support. That's why it's very important to have support for your elbows, but there's no support, so you're constantly holding up your entire arm. And that can weigh up to 10 pounds to 15 pounds depending on the individual. That's 10 extra pounds being supported by your neck and trapezius for about 8 hours a day. That gets to be wearing after a while. And that's why the trapezius muscles are very tight. And they don't only just cause shoulder pain here, they also cause neck pain and headache. When I was taking care of one of the magnet schools in Orlando, we had people, or kids and students from around the world. I remember that there was the Japanese kids would always come in with headaches, and we were trying to figure out why they would always have headaches. We couldn't figure out why. We thought it was the diet, we thought it was their stature, but we were able to find out that at night, late at night, they would usually study under the covers like this with their flashlights and their books, and they would strain the neck all the time, and that would usually result in trapezius spasm, headache, and then the pain. So you can see how just the shoulder, even though it is just the shoulder, you can wind up having a lot of discomfort in the front of the chest, in the back of the chest, towards the neck, and around the head, even towards the sinus. So always have to consider shoulders being the reason for anything in the girdle of the shoulder and chest. So this is a picture of how the shoulder sits on the chest. You can see that those small muscles called the rotator cuff muscles, they come off of the scapula. They are composed of small muscles under this spine, supraspinatus muscles. That's infraspinatus muscles, supraspinatus muscles on top, and then these muscles here called subscapularis. They all come together to form the rotator cuff. This is those three muscles come in, they cuff the head of the humerus. When the head of the humerus is cuffed, it can initiate, these small muscles initiate movement. This way, in the front, in the back. They initiate the movement, but the big deltoid muscle that you'll see in some bodybuilders, the three heads of the deltoid, the big deltoid muscle takes the movement from after initiation all the way up above the arm. So it has to be a coordinated effort. Even if you have big deltoid muscles, if you have a problem with the rotator cuff, it can still cause an impingement. An impingement is when this muscle in particular, the supraspinatus, gets caught underneath this thing called the acromion. And sometimes we'll get x-rays to see what kind of acromion people have. There's 3 different types, and type 3 is when it hooks down and it gives a higher tendency to impinge and irritate the supraspinatus muscle. The other thing that causes problems with impingement is even if the space is open, if the shoulder muscles are not controlling the movement, if you have trapezius muscle spasm, if you have irritation underneath the muscle, if you're hiking up and practicing bad form with throwing, the movement, the poor movement and coordination will cause the impingement to occur, and you'll have irritation. Once the irritation happens to the muscle, that sac of fluid in here called the bursa fills up with extra fluid, and then it becomes hot and irritated. Anything that you do at that point will irritate it and pinch it. There's positions and maneuvers that we do in the office to determine if it's an impingement or if it's a labral tear. There's also something that where the head of this humerus sits on the scapula. I can't show you here, but if you were to take this head off, you'll see a very shallow cup. That's where the head sits. It's a shallow cup, and that's why usually you'll have more so than the hip. The hip is a ball and socket, so you'll see that in the hip. The shoulder is very shallow, and it tends to come out more often. That's how you can have dislocations. But in the chronic patients or the people with chronic shoulder pain, sometimes when it dislocates a lot, like in double jointed patients, you can actually tear the labrum, and that's when you have a cartilage tear. The only way to find that is really just through an MRI with contrast of the shoulder. But at that point in time, usually we'll be seeing a surgeon. There's other ways to take care of shoulder dysfunction or trigger points. I like to use acupuncture to put needles into the muscle to relax it. Also put needles around the trapezius to relax the trapezius and have the shoulder settle down low instead of being hiked up all the time. It helps with proper function. When the shoulder is not functioning in the smooth manner to go up and down, depending on your lifting or lowering of the shoulder, it's called scapular dyskinesis. And when you have scapular dyskinesis, it's only a matter of time before the muscles give out, or one bad throw, one bad lift, one bad overhead movement will cause the impingement to occur, and then that dyskinesis results in a tear to the rotator cuff. Again, the rotator cuff and the cartilage, the labrum, are very delicate structures. The more bulletproof structures, the trapezius muscle, the rhomboids in the back, the lats underneath, or the pecs in front, they're bigger muscles and can tolerate a lot of ongoing work or labor, but they will fatigue after a while. And that's why it's important to know when to say stop your activity, your repetitive activity, or stop your exercise, depending on what you do. To know when to stop is important before the sloppy movement comes on that causes the tears or the pathology. What we can sometimes do to diagnose, if you can't afford an MRI, what I sometimes do if I'm thinking about a tear is I will put a steroid injection or a numbing medicine and inject it into the sac of fluid here. Sometimes that will numb up the muscle enough to have no more pain, and at that point in time we know it's probably going to be a rotator cuff tear or irritation. Instead of getting an MRI, we'll sometimes just wait, or we'll put steroids in after the shot, and that'll hopefully heal up fast. There are, for conservative measures, there are people who do prolotherapy. Ross Hauser is a guy in the area that does that. Not too many people are approved to do it, but he's had good success with labral tears or rotator cuff impingement. Something worth trying. It's just not covered by insurance. Acupuncture, I've seen some very good results with acupuncture, mine included. My story's in a blog. I'll put the link of the blog here. And you can see how I got by without getting my glenolateral tear, also known as a SLAP lesion. I got mine to resolve without any surgical intervention, but it took a lot of alternative medicine. So in addition, if you're going the conservative route, whether you have a tear or just bursitis, it is important to, again, decrease inflammation. That's omega-3 fish oil, turmeric, sometimes glucosamine sulfate if there is an irritation to the head of the humerus. All these things do help. Muscles, you can use topical, you can use Theracane to relax the muscle or the trapezius so it moves better. You can actually use magnesium as well. So all these things are in effect supposed to be helpful in addition to physical therapy or some form of therapy to reteach or retrain the individual how to move the shoulders properly again. I don't care if you're a baseball pitcher, semi-pro football, or you're just a guy that slabs or moves concrete. It's still important to relearn the small movements that help the rotator cuff before going on to those big movements that help the deltoid. My bodybuilders or my power lifters, great movements and they can tolerate a lot, but if the rotator cuff is torn, you have to revert back to the easy 2-pound or TheraBand exercises to rebuild the small muscle, gain range of motion, and then you can go back to the deltoid strength or the trapezius strength.